Добрый день, уважаемые коллеги-журналисты.
Good afternoon, dear colleagues, dear journalists, dear spectators of our broadcasting. We are launching the press conference of the scientists within the EECAAC 2018. Allow me to introduce the speakers first. In the far end, we have Beyrer from the US, 13th president of the IIS, professor of the Bloomberg School of Public Healthcare, named after John Hopkins. Mr. Beyrer has an extensive experience in international trial conduction in the area of HIV and AIDS prevention and in the area of studying HIV proliferation amongst key population groups. Mr. Beyrer knows our region very well since he was conducting his trials also in Russia, Kazakhstan, Southeast Asia, in China, US, and South Africa. Next to Mr. Beyrer, we have Peter Reiss, professor PhD in medicine of the Academical Medical Center in Amsterdam and co-chairman of the 22nd International Conference on AIDS that will take place in a number of months at the end of July 2018. Dr. Reiss has been working in several committees in Europe and US that were studying the national programs on clinical trials for HIV. Currently, he's the member of HIV monitoring fund in the Netherlands and other committees. Next to him, we have Sharon Lewin, director of the Infectious Diseases Institute, named by Peter Doherty in Australia. She has the interdisciplinary research group that studies HIV latency mechanisms, carries out clinical trials, and also promotes the promising strategies of treating HIV infection. Next we have Stefano Vella from Italy, who's the head of the Department of Global Research in the National Institute of Health, Italy. His activity is aimed at studying HIV resistance to ARVs, studying the immunity restoration mechanisms and improvement of ARV therapy. Dr. Vella was involved in creating international recommendations on clinical patient management, and he has taken place in over than 100 international conferences, and he was acting as an expert for many scientific magazines. Next to him, we have Vadim Pokrovsky, head of the Federal R&D Center on fighting HIV and prophylaxis. He dedicated 20 years of his life to, now it's 30, well, specifically 33. Actually, he's a corresponding member of RAMS and RAS academician. He was the first doctor to identify first HIV patients in USSR. He was taking part in creating the surveillance system, epidemic surveillance system, and he was part of developing legislation in the USSR and Russian Federation in the area. And now we have Salim Abdool Karim from South African Republic, who is the head of the research programs on HIV in South Africa. He is well known all over the world thanks to his R&D work in the area of treating HIV treatment and prophylaxis. And he has invested 20 years in the research of different drugs, and he carried out clinical trial on applying tenofovir gel, and let us, etc., etc. And let us start from the general questions, and if you have any extra questions from the audience, then we'll take them. First question goes to Vadim Pokrovsky. I think it would be nice if other speakers of ours will be able to reply to that as well. So recently, well, not recently, but now the pre-exposure prophylaxis is a trend. To which extent it makes sense to use that in the countries where the treatment is not sufficiently accessible? Does it make sense? Well, as our colleagues have demonstrated in their presentations, all the everything that can be done about to have the proper prophylaxis should be done. So pre-exposure prophylaxis is a very efficient method, and there shouldn't be anything against it. If there are resources available, and if legislation permits to have pre-exposure prophylaxis in place, then it should be done. Currently, we are planning to have this research in Russia to take maybe some implementing some specific approaches in terms of pre-exposure prophylaxis, something that should be applicable for our population. And our non-governmental organizations, from what I know, at least 2 of them, has expressed their desire to start using pre-exposure prophylactics techniques. But being a scientist, I should say that, yeah, I'm happy to provide my services to ensure that we get reliable results. It's very important in terms of advocating this method. We need to advocate properly when we present this method to people who make decisions, who provide the funding, for us to be able to use this method all over the country. Now, thank you. Maybe someone wants to add? Okay. Dr. Vella and Dr. Karim were present in this in such press conference 2 years ago, and you were very enthusiastic about IRV antiretrovirals of prolonged effect, but they haven't appeared yet. So, are we to expect that it'll happen sometime soon?
Thank you. So, having provided the initial evidence to show that antiretroviral drugs can prevent sexual transmission of HIV, I am very convinced that they are effective. I've also seen the data that comes now from studies that implement pre-exposure prophylaxis, particularly in men who have sex with men. And what we have seen are incredible data of a product, an intervention that is very effective in preventing HIV. But there are 2 issues in doing so. The first is to identify those at highest risk so that they would benefit from this intervention. And the second is to ensure that those who initiate this approach, that they maintain their daily tablets and that they adhere to their tablets in the long term. If they don't adhere, as we have seen in some of our studies, then they do not get the benefits of pre-exposure prophylaxis. I think, finally, that when we look at some of the big challenges that we have seen in the first few studies that have reported results on treatment for prevention, it becomes clear, particularly the studies from South Africa, that treatment on its own misses some populations, and perhaps we may do better in some of those circumstances to combine treatment and PrEP, and to look at targeted populations where PrEP could be beneficial, for example, in young men who are an important source of HIV infection in the hyper-endemic settings of Africa. So I think if we look at it that way, we have to look at it as a technology that has an important role to play, but a niche role to play, and we've got to make sure that once somebody started, they maintain adherence.
Mr. Vella,
Пролонгированный препарат.
Mr. Vella, if you might add, maybe there was a mix-up, prolonging not pre-exposure, but prolonged effect ART. Do you know of any kind, известны ли вам какие-нибудь разработки именно о АРВ-препаратах пролонгированного действия, которые имеют...
So are you aware of any developments of the IRV drugs of prolonged action? That was the question. 2 years ago, we had the information that they will appear sometime soon, but they haven't appeared yet. So do you know of any promising developments in this area?
Yes, they are not yet here, let me say, but progress has been made. We have seen new data at a conference now in the US. They are still under investigation. Actually, they are very promising, the recent data, but they are not licensed yet. To develop such drugs takes some time to prove that it's better than a pill a day, which is the usual antiretroviral therapy. Actually, there is also, we need to consider the two things. Apart from the fact that now there are more than a couple of drugs with constructed to be with prolonged effect. There is also studies on implantable devices, and so it's not only injectable, they are implantable. Implantable is like what women use for contraception. What's the advantage of implantable? Is that it can be taken out, because if you take a long-acting drug, when you inject, and so it's difficult to take it out. But the implantable is another, let's say, development. I think they will come soon. We need to also look carefully at, let me say, social sciences, because there might be individual patient preferences regarding the long-acting. Of course, they have an advantage in terms of compliance, because you don't need to take a pill every day and you don't risk to forget it. But some patients, we already have seen that some patients say, I may prefer to take a pill a day. So here is an area where patient preferences will be very important to when we will go to use them in the clinic.
Да, очень интересно. Я добавлю, что мы тоже принимаем участие в исследовании этих препаратов.
I would like to add that we also take part in research in these drugs, and it's an interesting thing that those patients who have been taking pills every day for many years, these patients are happier to switch to injections compared to those patients who start having injections straight away as their first type of treatment. So those who don't have this tough experience of taking pills every day, well, yeah, it's a first impression, and I have no rights to share the results of this research.
So just to add that from what Dr. Vella and Pokrovsky have said, that there are two ways in which we are using long-acting medications. The one is for treatment and the other is for prevention. In treatment, there are two lead drugs that are being developed. We don't yet have 3 drugs that are being developed. But the two drugs that are being developed have been used in combination in small studies that look promising. So I think we are likely to see it moving forward within the next few years. And perhaps when we are here again in 2 years' time, we may even have a licensed injectable. And remember, these injectables still have to be given roughly once every 2 months. So it's not like it's an injectable for a whole year. It's an injectable that still you have to come every 2 months for. On the issue of prevention, there are at least 2 lead agents that are being developed right now, and both look very promising in animal studies. Neither has been in humans yet, so it's a longer way away.
Спасибо.
Thank you. And now a question to Dr. Reiss and Dr. Beyrer. After the Berlin patient and a little girl from Mississippi, the world was inspired with hope of a vaccine, but years have passed and nothing is known yet. Do you have some realistic hope for a vaccine in the future?
So, I mean, you're alluding to the Berlin patient, which is really not about vaccines, but about cure, but I'm sure Professor Lewin will talk about that later. I think as far as vaccines are concerned, it's not directly my field, but I think what is important is that a few years back, based on a vaccine study in Thailand that showed some promise, I think a lot of basic science has occurred to really find out what a vaccine, potentially effective vaccine, should look like. And that has generated a body of research which has led to the generation and the production of vaccines, which now, of course, need to be tested in the clinic, and that's something that doesn't happen overnight, takes time. I know that in South Africa there is a large study ongoing, which is using a modified version of the Thai vaccine, or vaccine that was tested in Thailand previously. And it'll take some time before we see the data. I think the preliminary data that led to that large trial looked promising. It was very rationally designed, based on science. So I think that as a community and also as scientists, we realize that ultimately the vaccine and finding an effective vaccine is something that we definitely need. So personally, I think I'm very happy that all this research is going on. Ultimately, we'll have to see what the clinical trials show. In my own country and in my own hospital, there is a group that is very actively looking at doing research for many years at vaccines that may generate broadly neutralizing antibodies. They are now getting ready to the stage to do phase 1 studies in volunteers, so not prevention trials, but so all of this research takes time. But I think the important thing is it is ongoing. There's a lot of activity, and I think we'll need to be patient and hopeful.
I would just add that from a public health epidemiologic perspective, the timeline for both vaccine and cure research is long and uncertain. But the basics of HIV prevention, treatment, and care we have. And if we look at the epidemiology in this region, what we are seeing across Eastern Europe and Central Asia is rising rates of new infection. This is what I presented earlier in the day, and rising AIDS mortality. In the era where we have effective therapy and we have effective prevention tools. So I think a message that I would really like to get across is there's no question that we need ongoing investment in research, but that can never take the place of the public health priority and the clinical priority in front of us to use the tools we have already to address both HIV infections, which, as I said, are rising in this region, and AIDS mortality, which is also rising. And that is an issue of very low treatment coverage. The treatment coverage in this region is one of the lowest in the world, and that is why people are dying of AIDS. in this region. And so whether or not there's a vaccine or a cure, we have effective therapy, and most of the countries in this region have implemented universal access. So there's a great deal of work to be done with the tools that we have right in hand today.
Just to add a quick point to Peter's comment, I have never been as optimistic about the prospects of a vaccine as I am now. In South Africa alone, we have 2 large trials underway. One that is replicating what we saw in Thailand to see if that result can be replicated in an African setting. But to me, there's an even more exciting study called the AMP study, which is testing an antibody that has broadly neutralizing activities. Just to explain very briefly, every person who gets HIV develops antibodies against it. That's what the test measures. But the antibodies that are normally developed only can kill that strain of HIV. But there are these rare individuals who can make antibodies that can kill all kinds of HIV. So we have one such woman in South Africa called CAPRISA 256. Her antibodies kill about 88% of all viruses from throughout the world. So it's a broadly neutralizing antibody. It's also one of the most potent in the world. So now we've taken her antibody, we've genetically engineered, and we're manufacturing it, and we're about to go into trials with combinations of these antibodies to see if they would be effective in preventing HIV, so that it becomes a passive immunization strategy, but also lays the groundwork for a future vaccine that could be effective in prevention. So it's still a long way away, but we are much more hopeful given these results and the fact that these broadly neutralizing antibodies are so effective.
I just thought I'd make a point about cure, and first of all, just to pick up what Chris said, that antiretroviral therapy is absolutely fundamental to everyone living with HIV must be on treatment, because treatment saves lives and stops transmission. Also, people that aren't on treatment have millions and millions and millions of copies of virus in their bodies. And treatment reduces the millions and millions and millions of copies of virus to very, very, very low levels. And treatment never gets rid of those very, very low levels, which is why people have to be on treatment for life. If you've been on treatment for 20 years and you stop your drugs, the virus comes straight back up from these very few numbers of viruses that persist on treatment. So that's what the work in cure is trying to achieve. It's trying to get rid of those last few bits of virus that hangs around on treatment. So although we don't have a cure, and I don't think we will have a cure for many, many, many years to come, a cure will only be relevant for people already on treatment, because treatment gets rid of all of the majority of the virus, as well as saves people's lives. And tomorrow I will talk a little bit about what sort of things are being tried to achieve a cure, but to make the very strong point that we're at the very early days of where we need lots of basic research, lots of small clinical trials. We're still trying to find something that might work, and this is a very, very difficult problem.
Доктор Левин, мой следующий вопрос как раз для вас, может быть, в своем...
Dr. Lewin, I believe my next question will be to you. We would like to learn something about the results of your recent research of long-term remission and the syndrome of viral rebound.
Yes, so I might just step back a bit and talk about what we mean by cure and what we mean by remission. So cure means that the virus is gone away completely. We can't find any virus, and the person might even become HIV negative. Their antibody test will become negative. We only have one single person in the world so far that has been cured of HIV. So that tells you how rare that is, given there are 37 million people living with HIV. We have one person that's cured, who's the Berlin patient. We have a few more people that seem to be able to control their virus after treatment is stopped. And again, that is quite rare. And that's what we mean by remission. The virus is still there. You can find it using good tests, but it doesn't cause any disease, and it's at very low levels. And there's a number of cases of remission. I think the more common situation is people that are treated early in infection, so usually within 6 months of infection, before there's damage to the immune system. They're on treatment for 2 to 3 years to really bring down the levels of virus. And then they seem to be able to stop treatment and the virus stay at low levels. This is something we now call post-treatment control. And it may be more common than we think. And a lot of the work that we're trying to do is to understand what leads to post-treatment control and how we can give an intervention, a drug or a vaccine or an antibody that will induce post-treatment control.
Спасибо большое, доктор Lewin.
Thank you very much, Dr. Lewin. And we are ready to take questions from the audience, if you have them. You're welcome. We don't look like having any more questions, so let us thank the panelists, the participants of our press conference. Thank you very much for your time and for sharing the knowledge with us, and see you in the future. Good luck. Thank you very much.